I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenny as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone. Hey everyone, welcome to the Hormone Genius podcast. Today, Teresa and I are going to be talking about hysterectomy. And throughout the time, Teresa, of you and I doing these podcast episodes, some of my favorite moments are when I do Q&As with you, because I learn so much, and like you're kind of in the hot seat in a good way, and I get to learn a lot, and then you get to be, the pro. And again, when I say pro, so Teresa, she'll talk about her role with women who've had hysterectomies or who might need hysterectomies. She's not a surgeon. So when I say pro, I mean caring for that woman, especially after a hysterectomy. I think there's a lot of misinformation about even hormone replacement therapy, and we can talk a little bit more about that too. What are the health needs of women? What about women who've had hysterectomies very early in their childbearing years? What are reasons we need maybe where like really there's a call for hysterectomy for the health and safety of that woman? So we'll get all into that today. Teresa, are you ready to rock and roll?
I am ready. I am ready as I possibly can be. Yeah, I don't know. I did not sleep good last night, but
Oh man.
so I was up at 4 a.m. awake. You know how it goes. I'm perimenopausal. So what did I do? I started turning on YouTube videos about hysterectomy to prepare. So I am ready, but a little tired, but I'm
a little tired, but ready. Yeah. There we have it. Well, I know for me being also in perimenopause, so Teresa, you're 10 years older than me, I think, or 9 years older than me. I'm 41.
Mm-hmm.
How old are you?
50.
50. Okay. So I think as we age, especially, in this perimenopause age group, I feel like I'm hearing hysterectomies more and more and more, as opposed to when I was a younger gal. You know what I mean? So let's kind of go into, well, what is a hysterectomy?
Mm-hmm.
Are there different types of hysterectomies? When we say hysterectomy, what do we mean? And what are some maybe follow-up clarifiers when someone says, I need a hysterectomy or I've gotten a hysterectomy? What are basically the categories, I would say, in terms of that?
Very good. Yeah. And I will say I'm not a surgeon, although this is a great story. A patient in the last couple of weeks literally brought their operative report of their hysterectomy to me from 2002.
Oh.
And guess who the surgical assistant was on the operative report, Jamie?
Teresa, it was you.
It was me.
It was you? What the?
2002. And so I had this brief stint of being a surgical assistant with the surgeon that I worked with. And so I probably wasn't in more than a handful of cases like that. But anyway, she was like, look, your name is on here. And we just thought that was so cool. Anyway, but I'm not a surgeon. So I'm not going to speak as if I know how to do any of these procedures, but because I see and have seen so many women, I have a perspective, obviously, of what women experience going through hysterectomy. Mm-hmm. So what is a hysterectomy? Well, the definition really applies to one thing only. Hyster in Greek means uterus, and ectomy means to remove. So really, when we say hysterectomy, all we mean is that we are removing the uterus. Mm-hmm. And so then it gets broken up basically into what type of a hysterectomy are you doing, in the sense of, is it just removing the uterus? That's called a total hysterectomy. Or are you removing the uterus plus something else? And if you're removing something else with the uterus, then that is an additional kind of like procedure or term. So if you remove the ovaries with the uterus, that's called an oophorectomy, right? Oof stands for ovary. And if you remove the tubes, that's called a salpingectomy. So sometimes they'll say a total hysterectomy with bilateral salpingectomy oophorectomy. It's like a total hyster with BSO. Is kind of
Mm.
the acronym for it. And then there's some people who use this term, which technically, I guess it's not accurate, as a partial hysterectomy. And then, and it doesn't even sometimes make sense to me because, and this is a problem, Jamie, a lot of patients don't know what happened. And so they're kind of like, yeah, I had hysterectomy. And I'll be like, well, do you have your cervix still, or did they take it all? And they're like, I don't know. I'm like, do you have your tubes or your ovaries? You're
Oh
like,
my.
I think they left them. I think they took them. So if you're a patient, it's really good to know what exactly was done, because many of my patients, sometimes they don't know. It happened
Right.
years ago, and they're like, I think, so whether we're going to continue like screenings like pap smears depends on whether the cervix is there. And you can actually leave the cervix and only take the upper part of the womb, because the cervix technically is its own organ, even though it's connected to it. And it's like, the if you don't know, your uterus is like a light bulb in some sense. It's like the upper part is kind of a round, kind of pear-shaped muscle, and then the lower part is like this little stem, kind of like a light bulb. And so they can leave that, and they don't do that very often, but in some cases, due to like a complex case, like with scar tissue, or if the patient just wants it left there, some patients prefer it, even though they have found it doesn't necessarily help to leave it. So
Okay.
that might be considered something called a partial hysterectomy.
We got to push a big old pause
Yeah.
button on this one. Okay. Because earlier when you said, is your cervix still there? I was thinking, did she mean that? I was thinking that as you were talking. I'm thinking, how would you leave the cervix there and get a hysterectomy?
Yeah.
And then you just said what you said. So then my thought goes to, okay, so if there's the cervix and it's its own separate organ, which I can honestly say, I didn't realize that I didn't realize. I just thought it was all one, and it is, it's all together. I didn't realize though they're considered two separate organs. But if you do leave your cervix and you leave your ovaries, I mean, can you still make cervical mucus? And then number two, the question is, if there is just the cervix and then the uterus is gone, I have a lot of friends who have like uterine prolapse and like the prolapse problem. And we think about like when you remove an organ, like everything else kind of can shift and whatever. So if the uterus isn't there, it's just the cervix, does it kind of fall more than it would otherwise? Those are all my questions.
Yeah.
Answering them in whatever order makes sense to you.
Yeah. Okay. So the first is yes, you can make cervical mucus if you've left your ovaries and the cervix is still, absolutely. And actually, some people apparently can actually have a period, a very light period monthly, because they're still ovulating if you have your ovaries. And if they just accidentally leave a little bit of endometrial tissue at the top of the cervix, I
This
have
is
actually,
crazy,
I know, I've never
Teresa.
seen this. I should
What?
have looked up the statistic on how many people leave their cervix, Jamie, because we're in some ways like down a rabbit hole, because like not
Sure.
that many people do,
Right.
although I have seen it. It's not rare. There was this period of time where they thought if you left the cervix, it would help the structural support, like you could
Right.
maybe hold things up better, and
Okay.
that maybe it would help with sexual function.
Mm.
Like years have gone by and they've kind of realized that wasn't really the case. So they're
Mm.
really recommending people remove the whole thing. It's
Mm.
kind of more of an updated recommendation there.
I see.
So yeah, anyway, but yeah, so let's go back to how many, like the basics. Again,
Yeah. Yeah.
hysterectomy, second most common gynecological surgery. They estimate around 500 to 600,000 procedures, hysterectomy procedures a year, which is a lot, but
Mm.
they have reduced over the last 30 years. There has been a significant reduction, and that's because we do have more treatments for the most common reasons that people would have hysterectomy. And the most common reasons are fibroids.
Mhm.
Fibroids, hands down, are the most common reason for hysterectomy. It makes up about 30 to 40% of why women would have a hysterectomy.
Mm.
The second most common reason would be abnormal uterine bleeding or heavy menstrual flow. And then there's a variety of other things like prolapse, malignancy, so cervical or uterine cancer or ovarian cancer. Um, did I hit them all? Adenomyosis and endometriosis. And so those are all of kind of, I haven't hit them, I'm sure I'm forgetting some, but kind of the bigger ones in terms of why a woman would have a hysterectomy. And by the time a woman is about 65, it's kind of like close to one in, 3 women that have had
Whoa.
one. Yeah. So it's a lot of women, but I think what we need to kind of really focus on is, again, what would be really the reason you as a person would really make that decision, because
Mhm.
it's a significant one, right? And then are there other things that you could try first, right? So, like, most people aren't looking to have organs taken out of their body and have a major surgery. So I think most women want to have all of the other options presented to them and then make the decision on whether they would have a hysterectomy. So these are all really important questions for people to really walk through with their own personal doctor.
Okay, so Teresa, you said that hysterectomies are less common, now as compared to earlier on, and you gave some examples as to why women would get hysterectomies, where now maybe they don't need to get these hysterectomies. You mentioned adenomyosis, fibroids, endometriosis, really heavy bleeding, of course, cancers and that sort of thing. I can imagine with cancers and that sort of thing that they would take the uterus, of course. But what are some of these issues, these health issues that were just mentioned that you could maybe work with the woman, you or the OB-GYN or the surgeon or whoever, the professional, so that they don't need a hysterectomy. Like, especially I'm thinking fibroids because there's a lot of women, of course, like you said, fibroids are so common. And adenomyosis, I have quite a few friends who that is their diagnosis. So, what are the alternatives in terms of a treatment plan?
Yeah, and this is where, we've got some newer kind of surgical techniques, one being endometrial ablation, which is more common procedure, not as common as a hysterectomy, but more common, like in the sense of maybe 300,000 procedures a year, which probably has cut down hysterectomies quite a bit. What is an ablation? It is where they put hot water into the uterus, and they basically burn the inside of the lining of the womb and they destroy it.
Mm.
Now, this is very effective for a lot of women who are at the very end of their perimenopause journey and they've been dealing with heavy bleeding. Fibroids, again, the biggest risk factor for them is heavy bleeding, abnormal bleeding, and sometimes if they're very large, they can cause a lot of discomfort and pressure.
Mm.
So I would say endometrial ablation is a procedure that has allowed for some women with fibroids to take a different path than actually removing the uterus. Another procedure is uterine artery embolization. This is much more rarely used, but that's something at least that is a radiology procedure that is now being done that may prevent a woman from having a hysterectomy because that reduces and shrinks fibroids. And the other things would be hormonal. We have really good treatments. I mean, the way I approach it, of course, it may be different than a traditional OB/GYN. A traditional OB/GYN might use an intrauterine device like an IUD, and they may use that to control bleeding. And that does work for a lot of women. Some doctors use birth control pills, and again, there is a lot of side effects to birth control pills, but sometimes a woman can make a choice because that was better than bleeding, erratically.
Mm.
That's not what I use because I prefer bioidentical hormones and I try to avoid those side effects in my patients. And most of my patients prefer that as well. So we use a lot of progesterone. And what I use is high dose progesterone, bioidentical, but higher dose to really, really affect the bleeding patterns and shed off that lining in a really effective way over time. So that periods over months and even years on bioidentical progesterone just get lighter and more
Mm.
controlled. And then we have medications like tranexamic acid, which slows down bleeding in heavy flow. We also use nonsteroidal anti-inflammatories like ibuprofen in a very effective way to control heavy bleeding. So those are the things that we are, looking at as alternatives to, removing the uterus in a situation like fibroids.
So with the high dose progesterone, like what would be that dose?
I mean, I use anywhere from 300, these are higher dosages than typically, like, 200 is an average dose, but I mean, I can use upwards of, I have one patient on 800 milligrams.
Whoa.
That's a lot, but this patient has really heavy bleeding and she is wanting to preserve her uterus. And so again, this is where these conversations of like, what is best for you as the patient, that someone may choose that this is just too much and they were like, I cannot do this anymore. And another person be like, do whatever you can to preserve
Yeah.
this organ.
Hmm.
And so I think, honestly, in most situations, I think if someone wants to preserve their uterus, they can. I think malignancy is certainly a situation where maybe that's not possible with cancer, but in a lot of situations, we really can walk through somebody's situation and help them find a pathway maybe that wouldn't lead to the uterus coming out.
Right.
So these are where it's really important to have a trusted healthcare professional that you can have this conversation with.
Right. So when you mention fibroids, we hear fibroids a lot. Remind our listeners, what are fibroids? Why
Mm-hmm.
does it cause heavy bleeding? And what's the difference between fibroids and polyps? And then do polyps cause heavy bleeding, or is that something completely different?
Fibroids are benign tumors that grow in the uterine muscle, sometimes on the outside of the uterus, sometimes even in the womb lining. Fibroids are never going to become cancer. They're fibrous material, very dense. They form balls, kind of like tennis balls. And sometimes they're a variety of sizes. They could be as small as, a quarter upwards to a cantaloupe.
Mm,
And when they become very large, it's obvious in some ways why, when they're large, they disrupt the environment of the uterus quite a bit. When you have just multiple small ones, what it's doing is making the muscle less effective at being able to just release that lining in a real succinct way. So, and then when they're in the womb, like a polyp, an endometrial polyp is something that's actually stuck inside the lining of the womb. And that is more of like, I call it like a skin tag. It's like an overgrowth of endometrial tissue. That is different. That doesn't necessarily always cause heavy bleeding. It usually causes intermenstrual bleeding or in between the period bleeding. And that can be easily taken care of, an endometrial polyp, without removing the uterus. So that usually isn't something that leads to a hysterectomy. Now, if you have multiple tennis ball size fibroids, those are hard. And so that is something where somebody might just say, this is so big, so bulky, my uterus is now, it's putting so much pressure on things and it's causing so much disruption, that someone would say it's better to take out their uterus.
right.
Um,
Right. What about uterine prolapse?
so yeah, we've had an episode on prolapse too. And it is tricky because in some ways, yes, if your uterus is falling out, which we talked about how the bladder can fall down, the rectum can kind of fall down, and then the uterus and the cervix can fall down into the vaginal canal too. But it's more common for the bladder to fall down. And if you take out the uterus, in some ways you're losing support, right? Because all of these ligaments, there's like 8 ligaments that attach to the walls of the pelvis to keep everything up. And so when you pull out a big organ that's in there, like the uterus, you're actually losing support. So you would only do a prolapse or hysterectomy for prolapse when truly the significance of the prolapse is affecting the person's quality of life heavily. Like it's really dropped down and it's almost a danger to the patient.
Right.
And so prolapse is common, but it's not a super common reason for always doing a hysterectomy, because again, there's other things that we can do a lot of times. And um, we can support the bladder and the rectal tissue in different ways as well.
Right. Yeah, I want to just share a quick story, and then I really want to talk about how you support the women after they've had a hysterectomy. Okay, so Teresa, you know this, of course. I haven't shared this with podcast world, but this summer I found out that I had a tumor, a complex cyst on my right ovary. My right ovary is very large, like 6 centimeters. I can't remember how big it was, but it was big. It didn't cause me any pain, and it was a total accident how we stumbled upon this tumor. And so the only way to really know if it was a danger was to remove that right ovary and that right tube. So that's what they did. And what was interesting was also in all of this, my bleeding, my periods were so heavy. The last couple years, periods have been as heavy as ever. And I thought to myself, so if this is you ladies, I'm just giving you some advice. I thought, because of course as we get older, our uterus ages and it's normal to have heavier bleeding. So in my mind, I just kept thinking it's normal, it's normal, it's normal. And I got lab work done and my ferritin levels were 4 because my bleeding was so heavy. And again, I didn't realize myself, me, Jamie Rachi, like co-host of the Hormone Genius podcast, fertility care practitioner, XYZ, blah, blah, blah. I did not know that that was so not good. I mean, I did once I figured it out, but I didn't realize, oh, that's why I'm so tired. You know, my bleeding is crazy, but I just thought, oh, I poo-pooed it, basically. And then with all this coming to be, when I was getting surgery, the gal, the surgeon, she kind of she did a DNC. She kind of cleaned out the inside of the uterine lining because there was a thickened wall part, okay? The next cycle after surgery, she told me, she said, this bleed will be light and it'll be awesome. And this is your baseline. So if it gets worse than what you experienced the first two cycles back, we need to do something about how heavy your bleeding is. And so the first cycle back, it was the heaviest of my life, of my life. Literally, I don't know if this is, I mean, it's fine. Listeners, if you have a 12-year-old who just got her period, like push pause and don't let her listen. I had like 3 ultra tampons up there. Like I'm bleeding out. It's on my mattress. It's everywhere. Blood, like crime scene. Like I couldn't even sleep a full night without just completely losing. I was losing so much blood. I thought this is wrong. There's something really wrong. So I went to the doctor and I said, "Listen, this is bad. Really bad." And she said, and I said, I think I'm going to experiment with more progesterone, and see what happens. And she's like, that's not going to work. It's not going to work. The only thing that will work is if we put you on birth control. Now, she doesn't know me. I don't have a close relationship with her. Of course, I said, no, thank you. And I said, I'm going to try progesterone. No, it's not going to work. It's not going to work. And I said, well, let me be your experiment and I'm going to do it. So guess what? I took the progesterone and the next cycle was awesome. Teresa, not only did the heft of flow drastically decrease, drastic, the number of days I bled way shorter. Instead of like 3 so heavy days, like debilitating almost, I had 1. And like the number of tampons I used was like a half of a box of the Ultra rather than 2 full boxes of the Ultra Big. And I thought, wow, that was last cycle. This cycle, I just finished my period. Guess what? Same thing happened. It was the best period of my life. So I'm saying to those of you listening, your OB-GYNs or whatever, your doctors, they're not going to think that's going to work. But it really worked. And I even got that transin something acid. How do you say
Yeah.
it?
Transamic acid. Yeah.
Transim. And I did do that last cycle. So in my head, I'm thinking, I only used it a couple times and I thought maybe that's why. But this cycle, I'm like, I'm not going to use it. I'm going to really see, is it the progesterone? And it was. It
Yeah.
really was. I didn't need the however you say that. I can never say it. Tranexamic acid. So I had to say that story because again,
That's so good.
oh, praise
Such a
the
great
Lord.
story, Jamie. I'm so glad you told that on the podcast because that it'll help so many women
Yeah.
to advocate for themselves. But so many women go through this, like the
Yes.
heavy flow as they hit close to 40s, and they sometimes don't speak up. You know what I
Mhm.
mean? They just like live with it. Like so many women I know, like
Yeah.
that I've seen, they just like, well, yeah, I like literally can't go anywhere for an entire day, but they just don't think anyone's going to help them. And
Right.
I just want to say to you out there, like Jamie's story is valid and true, and progesterone does really work for most people. And I would often tell any patient that, like, if you want, I can work with you on progesterone and we'll probably get this right because
Yeah.
progesterone stabilizes the bleeding and allows that lining to thin out. So,
And it's helped my family in incredible ways, obviously. I mean, kind of common sense says, wow, if mom's not up sleeping all the time, she's with the family. But my husband just got so used to just, she's on her period. And it wasn't like that always in my life. It's just really been the last couple of years, and it's been really bad this year. So I've gone to the gym. I don't even know if I took a nap this period. I don't think I did. It was crazy. I thought I feel like myself. Like I think we get so used to this.
yeah.
And it's kind of like, that frog in boiling water, that saying where it gets a little hotter and a little hotter. The frog in the boiling water doesn't realize that temperature is increasing. I think that's what we do as women. That's what happened with me. It just got a little worse, a little more often. And I just kind of rode that wave and praise the Lord. I have friends like you. And again, people who should know better like me. I literally just thought my age and that was the excuse for it.
Well, and it's
And that it was the
if you have
reason, but I
heavy
just didn't know
periods to
how.
get
Yeah.
your iron levels checked too.
Oh,
Just
get your
get your
iron.
iron
Oh,
levels checked. If you have heavy flow and you are tired, like guys, just go get your iron levels checked because you can replace it either through oral iron, but sometimes you need an IV iron infusion and that can like change someone's whole life,
and
right?
that's
And
what I did. I needed an iron infusion. And I remember being so nervous because I've heard about like iron poisoning and whatnot. And Teresa, you're like, Jamie, shush, just go, just do it, you know? And I'm so glad I did because now my iron levels are totally fine. But they were definitely not earlier. So sorry, that was like a side story I wanted to make sure I inserted.
yeah, that's great. Yeah, so let's talk about the
Mhm.
adenomyosis because you mentioned that with your friends too. So
Yeah, yeah.
adenomyosis, also a condition that can cause a lot of cramps and heavy bleeding. Unfortunately, it's like endometriosis, but it's in the uterus, and there really isn't a cure for it. So
Mm-hmm.
although I have worked again in progesterone and treating with progesterone may help that, there are situations where if the pain, especially the pain and the bleeding together is so bad that someone might choose a hysterectomy. So that is a valid, I guess, cure for adenomyosis. Um, Now, here's a caveat about endometriosis and hysterectomy. So there are patients that I've seen who are like had terrible endo, and then they're like, I'm done. Like, I can't do this anymore. Like, my periods are so terrible. Just take out my uterus.
Mm-hmm.
But they don't really get the endometriosis. Like you take out the uterus, but if you got endometriosis all over your pelvis, bladder,
Mm-hmm.
rectum, that ain't going to cure your endo. And
Mm-hmm.
if they leave your ovaries, you're still going to have pain potentially.
Yeah.
Yes, you won't bleed, and that will be a relief. That there's part of it certainly that could be a relief, but you might still end up with pain because the endometriosis part wasn't addressed. And so that's just important to remember if you have endo and somebody is like, hey, well, why don't you just take your uterus out? That's another thing you have to think about. Well, if I take my uterus out, will that really fix the problem fully?
Right. Um, that's such a good point. Really important to consider that. I once worked with a gal who had endometriosis in her neck, and I know in the endometriosis episodes we talked about kind of all the places that can be, which is important to think about. For going back to adenomyosis here, quick before I move on. So I have two really good friends. They both have adenomyosis, and one in particular is desperate to achieve pregnancy. Desperate. It hurts my heart, like just and is that cause for infertility or is it a cofactor? Like, could
Yeah.
it be reason enough that
Yes.
someone's not getting pregnant? Okay.
Yes.
Mm-hmm.
Yeah. Yeah. Not that it can't be addressed. And, with really, really good doctors, there's just a lot of things to look at with that. But yeah,
Mm-hmm.
it's definitely a hard one, really a hard
Yeah.
condition for sure.
Yeah. Okay.
So I
Yeah.
feel for her.
Yeah.
So yeah,
Okay.
go
Oh yeah.
ahead.
I was gonna say, moving on. So a gal comes to you. She's had a hysterectomy, and thankfully so. Perhaps again, really, it was cancer, super huge fibroids, whatever the case is. Or even maybe she mourns the loss of her uterus, and maybe she feels like maybe she shouldn't have had a hysterectomy. But either way, whatever the case is, how do you care for her hormonally, and how might that change based on her age and stage, or does it based on age and stage? Because I know, if it's a hysterectomy plus an oophorectomy and all of those, they're taking out the ovaries and you're not getting those hormones, that will be different than if the ovaries are put. So let's kind of like break that into categories and talk about how you'd manage that.
Oh man, one of the most devastating cases that I see, and it's not very often, thankfully, but is a patient that had a hysterectomy who had her ovaries removed. So, like as you said, took everything, and the doctor did not. So the patient was before the age of menopause. So, and I remember one girl was in her 30s, and the doctors did not advise this woman to be on hormone replacement therapy. Here's the key: if you remove your uterus before the natural age of menopause, you will lose all hormones in an instant and in forever.
Mm-hmm.
So, and that has catastrophic effects on the body in some ways. I mean, I don't want to be I mean, I'm being dramatic about it, but what we know is that it increases the risk of dementia. It increases the risk of heart disease. It increases the risk of osteoporosis. It decreases your quality of life. And so you as a patient need to understand that if you are premenopausal, that your ovaries would have been making hormones and you're choosing to do a hysterectomy and they're saying, do you want us to take your ovaries? You should really say no, unless those ovaries have significant damage or cancer or something in them, or you have some other reason, like you have the BRCA gene or Lynch syndrome, which are genetic conditions.
Right.
And even then, you should be on hormone replacement therapy after that. Because again, this isn't just, oh, you'll feel better on hormone replacement therapy. This is like, no, this is longevity and lifespan decisions.
Yeah.
So
Oh my gosh.
that is so key. And so when I have seen those cases and I cannot go back for them, I cannot go back. And now they're seeing me at 50. I'm like, holy Moses. How, I mean, to me, it's absolute medical negligence.
Yeah.
If they were not counseled appropriately in that way.
I have a friend who she was getting a hysterectomy. She's not a super close friend. Not a friend where I can like give her advice and she listens. Kind of more of an acquaintance. And she's like, I'm getting a hysterectomy, and I told him just take everything. I'm like, no, just take everything. I've had enough of it. I've had terrible periods. Just take it all. Take it all. That was her viewpoint, and she didn't know. She had no idea. And guess what? They took it all.
Oh,
Did they
no.
need to? Nope. They did not need to. She had huge fibroids, like you were saying. Terrible, huge tennis size, cantaloupe sized fibroids. Take it all. They took it all. They took it all. And she's my age,
Yeah.
you know? So, so frustrating. Another friend of mine had a hysterectomy, complete everything in her. She was 30 years old. Now she's 50, or 55. And she was on zero hormone replacement, anything. I think she was maybe right after, but then she started going to a chiropractor, and the chiropractor said, you need to get off that immediately. Get off of it. That is so bad for you, this hormone replacement therapy. And she did. So
No.
she has, I mean, struggles with bone, like her bones, obviously. And it's just, she always says, oh, I have hollow bones. I'm like, well, maybe. I mean, like, it's
Yeah.
terrible.
Yeah, you don't want to like, yeah, these
Terrible.
poor women, they've made the decision. They
Yeah.
have to live in it, but we want to change this for the future. And so
Yeah.
this will bring up, Jamie, what happened on November 10th, 2 days ago. And this is
Yes.
a huge shift, right? And I
Praise the
was
Lord.
listening to some podcasts or YouTube videos that were like, one doctor did say, like, well, you should only be on hormones for the shortest amount of time at the lowest dose. And I'm like, dude, you are so in the 1970s, like, get with the times.
Yeah.
So finally, the FDA has removed black box warnings on November 10th, 2025 from hormone replacement therapy so that women cannot feel this like fear
Yeah.
around something that literally will allow them to live longer
Yeah.
and like prevent their brains from working right. I mean,
Mhm.
it's crazy. And as Peter Attia has said, the single biggest medical tragedy in
Yeah.
the last 50 years. And
Mm.
so for all of us, until we know better, we can do better. So for any woman out there, if you have had a hysterectomy and you are before under 50, you need to be asking about hormone replacement therapy, and you need to be asking about it. And then you need to continue to assess your situation, but continue on hormone therapy as long as possible in most situations for longevity and lifespan. I'm not going to say like, oh, you shouldn't. There's just like no risk at all. Like, although I think that's so minimal and the benefits are so high that for the vast majority of patients, hormone therapy in any situation going into menopause should be strongly considered at this point.
Yeah.
So, and especially if you are premenopausal and have a hysterectomy,
Yeah.
you really have to protect your body and advocate for yourself.
Yeah. So important. So important. Okay, well, Teresa, there's so much more. What's some last thoughts? Because I really want to make a really exciting announcement about something that Teresa and I are offering, and I want to also shout out to our podcast partners, We Heart Nutrition. So I'm going to do that, I think, at the end as we close up. But Teresa, so we talked about, of course, the reasons why a woman might need a hysterectomy, that hysterectomy numbers are coming down, praise the Lord, because there are other ways to help manage these cases. Hormone replacement therapy is not the evil that it was assumed to be. And of course, we want bioidentical, not synthetic. So that's a big difference. What other advice would you give to these women post hysterectomy in terms of caring for their body?
Well, I also want to mention that even if you leave your ovaries, you still have some change in hormones, most likely. And they've studied this. They actually do show that there are changes that still occur when you leave your ovaries, and it has to do with the ovarian blood supply. We don't know as much about this, but I do think you need to be very watchful, even if you have a hysterectomy and leave your ovaries, about how you're feeling. Because many women will feel changes in like perimenopause to menopause symptoms, hot flashes, night sweats, brain fog, lack of libido. Like, so you should advocate for yourself in any situation, leaving the ovaries or not.
Mm,
I also do know that from a identity standpoint as a woman, our uterus is this great organ, right? This this incredible creator of life, this body part that we have. It is important to us on so many levels. And if we've given birth to children, getting rid of our uterus is a very emotional thing.
yeah.
And so we don't take that lightly. And and I think talking to other women who have had hysterectomies, if you are a woman that has, and sharing your thoughts and feelings around that is probably really important.
Hmm.
Because I do think we kind of just take it for granted. This is like, whatever, right? You lost your uterus, no big deal, right? You didn't need it anymore. You weren't going to
Hmm.
have any more children. But I see women really, in a sense, weep,
Hmm.
literally weep, or sometimes just they're weeping inside
Hmm.
because they've lost the a sense the deepest feminine truth that they have,
Hmm.
which is the womb.
Hmm.
So I just wanted to bring that up, and I also wanted to bring up that, I mean, going back to kind of the beginning and how these surgeries are done, and they have all these technical kind of names, that we've gotten a lot better at hysterectomy from a standpoint of how we do it. So
Yeah.
now they used to be done where they cut your stomach open, kind of like a C-section, right?
Yeah.
And that was much more recovery and big deal surgeries. And now
Yeah.
we do minimally invasive hysterectomies, either done vaginally or with a laparoscope or even with the Da Vinci robotic procedures. So they're much, much better at doing them. Many women go home the same day or
Yeah.
even the day later, and they're recovering in a couple weeks to, a month. So that is a good thing about hysterectomies, is we've gotten a lot better at them. But the conversation just, we can't, I wish we could just spend so much more time on it, but we just really want you to talk to your healthcare professional. And I just, more than anything, want you to know that ovarian hormones are so important to you. And
Hmm.
you should ask questions and get all the informed consent and information that you need to make the best decision about where you're at in life with your hormones, and advocate for better. Advocate for a better quality of life. It always can get better. If you are suffering, we always can make it better. Not perfect, but better. And better is good.
Right, exactly. So beautiful. Such an important thing. And I know 2020, my mother was in the hospital for a month with a bowel obstruction, and it was scar tissue from her hysterectomy.
Mm.
And they said like 80%, I don't know if that's what it was, but an alarming rate of women who have bowel obstructions is from the scar tissues from their hysterectomy. And I'm thinking, what? Like, so, again, advancing this medical surgical procedure, like you're saying, Teresa, I hope that that would not be the case. I'm thinking even
Yes.
how that would. So praise the Lord for that. Okay, so Teresa, thank you. I learned so much. I really like this episode, Teresa. It's like one of my favorites of the season so far, I think, because it's a topic that I don't see a lot of people talk about, and it's important. So, with that, I want to give everyone an amazing announcement. Those of you listening to this episode and enjoying it, this announcement will appeal to you, I have a feeling. So, Teresa and I have worked so hard, so hard to release a perimenopause course. And it's awesome. And it's only $97. So go to our website, hormonegenius.com. You will see an announcement on the banner. Hey, guess what? New release, our perimenopause course, $97. Teresa and I walk through 4 pillars of perimenopause health. We have lots of bonuses. We talk about hormone replacement therapy even more. We talk about cases and how we helped these women that struggled with the symptoms of perimenopause, plus even more, so much more. So $97 is all it is to invest in your health. If you are in perimenopause, please go to our website and check it out. Also, shout out to our podcast partners, Better Late Than Never, We Heart Nutrition. They have an amazing supplement called like Wholesome Support 40 Plus or something like that, I think. And check that out because that will provide the nutrition we need, especially as our bodies are changing in perimenopause. Of course, the magnesium glycinate we goo on all the time. They have an iron supplement, which is what I take. So if you have heavy bleeding, please check out weheartnutrition.com and type genius at checkout for 20% off of your first order. So, Teresa, with that, thank you so much for your knowledge, and I will see you in our next episode.
Thanks, Jamie.
Thanks for listening to the Hormone Genius podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel, so if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.